Sam Ganahasa is with the LLINEUP team. So he's the, I think, data manager for the LLINEUP team, and he'll be talking to us today, just briefly giving us some introduction to that study. And then one of the exercises in the next session will also be focused on this LLINEUP study. So we appreciate him joining us. He's calling in from Uganda, so we appreciate having him here today. Go ahead, Sam.
Go ahead, Sam. Feel free to unmute yourself and you can get started.
Okay, thank you very much. And thanks, Shena, for that introduction. As Shena is trial manager, worked as a trial manager for the LLINEUP study, not data manager, just correct that. So just presenting work on behalf of a group. Of course, it's a big group that's done this work, and it's really the LLINEUP project, which is the effect of long-lasting insecticidal nets with and without piperonyl butoxide on malaria indicators in Uganda. So this was a cluster randomized study that we did. So by way of background, really until recently, all LLINs have been treated with pyrethroid insecticides, and really evidence on new generation LLINs incorporating new compounds is really needed. And that is, part of the reason why we undertook this trial. So the Ministry of Health, together with partners, opted to deliver nets containing PBO in the 2017-18 UCC. So that's the last UCC that happened in Uganda. So both LLINs with and those without PBO were deployed nationwide, and really just provided us an opportunity to rigorously evaluate LLINs on a large scale. So really in collaboration with the Infectious Diseases Research Collaboration where I work, the Ministry of Health carried out this cluster randomized trial in 48 districts. That's about 40% of Uganda's area. So 48 districts in eastern and western Uganda. So the ministry was really responsible for delivering the nets, while IDRC did the randomization and also conducted the evaluation. And so really it provided us, in a way, a chance to test out a new model for evaluating malaria control interventions. So our research question was, are combination LLINs with PBO more effective than conventional nets without PBO for malaria control in Uganda, particularly in areas with high levels of insecticide resistance? And our primary objective was really to evaluate the impact of PBO nets as compared with these conventional nets without PBO on parasite prevalence. And so we really aimed to test the hypothesis that malaria burden measured by parasite prevalence would be lower in clusters randomized to receive PBO nets. And these are listed down here. Our secondary objectives were also comparing the impact of permanent 3.0 versus 2.0, and then Olicet Plus, which is a PBO net, versus Olicet net, which is a conventional net. And then we're also assessing LLIN durability, bioefficacy, survivorship, and use. I'll not be presenting all the results. I'll only be presenting key results. So in terms of study outcomes and measures, our primary outcome was parasite prevalence by microscopy among children 2 to 10 years of age. And the reported measure that I will present here is prevalence ratios in the PBO versus non-PBO arms. And the analysis was adjusted for baseline prevalence and as well for clustering within households. And then our secondary outcomes as listed there, we had some outcomes on LLIN ownership coverage and reported use, and they are all defined as you'll see on the slide. We had an outcome on anemia prevalence. I will not be really talking much about it today, but we also had an outcome on household vector density, which I will present. The reported measure there was density ratios between the PBO and non-PBO arms of the study. So in terms of study design, as we said, it was a cluster randomized trial, and we took our cluster to be a health sub-district. We had 104 of these health sub-districts in these 48 districts across eastern and western Uganda. We excluded regions receiving IRS with Actelic. I think at that time, the WHO had given some guidance saying there was some antagonistic effect between Actelic and PBO. And so on the basis of that guidance, we had opted to exclude those. That guidance has since been retracted by the WHO, but at that time, that's what we did. So we had health sub-districts randomized to PBO and non-PBO. These were stratified by region to account for regional differences in insecticide resistance, and also we did a proportionate randomization according to the number of nets available from the manufacturers. And so we really had 4 types of nets. We had 2 PBO and 2 non-PBO LLINs. So the nets were distributed by the Ministry of Health, to all sub-counties within a health sub-district or within a cluster, according to our net allocation list, which we had generated from the randomization, and there was no overlap in that. So this is a map showing the study sites and the randomization. As I said, we had 104 health sub-districts. 52 actually received or were randomized to receive PBO nets, and then 52 to receive non-PBO nets. And you can see the different types of nets in that map, the OLISET net, OLISET plus, permanent 2.0, and permanent 3.0, which is also a PBO net. So I'll skip on to the evaluation. So in terms of evaluation, we did a cross-sectional survey, which was really led by IDRC. We did some surveys at baseline at 6, 12, 18, and also at 25 months. We had a community household survey done in which we randomly selected 50 households from each of the clusters. We did a household questionnaire, including measures of LLIN coverage and adherence, as well as clinical surveys of children aged 2 to 10 in those households. And we did also hemoglobin testing for children aged, 2 to 4 or under 5. And as well, in 10 households of those which had been included for the community surveys, we also carried out entomology surveys, collecting resting mosquitoes using Procopac aspirators, and we did genotypic monitoring for insecticide resistance markers in those mosquitoes that we collected. As well, we did some net durability and bioefficacy work, withdrawing 400 nets from the clusters, 100 per arm. We are withdrawn and replaced at the 12 and also at the 25-month surveys. So coming to some of the results, baseline, just giving a brief on the baseline results just before the rollout of the nets. Baseline parasite prevalence, as shown here, in children 2 to 10, overall was 26%, but it really ranged widely by region, with some regions having, almost as low as 0, while there were regions which had as high as, 50, almost 70%. Parasite prevalence. So it kind of really ranged, as you will see in this heat map, and it seemed to increase with age, and there were other factors that were associated with parasitemia, like living in poorer households, living in a traditional house, and also inadequate LLIN coverage was associated with the parasitemia. And this is published in one of those papers that we've cited here, Rubnao and myself. So moving on, just to give a summary of the baseline survey findings, I want to just show that map for parasite prevalence. But as well, we realized that between 2014-15, when the last campaign had happened in Uganda, and this baseline survey, LLIN ownership and coverage had reduced markedly, and only 15% of residents lived in a household with adequate LLIN coverage at the time when we did the baseline survey. And remember that this is prior to the distribution of nets for this PBO for this study. So parasitemia and anemia, I've already talked about this, varied widely by region, and like we said, it really varied by region. I will not go into much detail there. But then also talking about the species of mosquitoes, Anopheles gambiae was really the predominant vector across all areas. And there were really no differences in vector densities or resistance markers by study arm at baseline. However, KDR mutations were close to fixation in the Anopheles gambiae species of mosquitoes. So really, we have widespread pyrethroid resistance within the area. And as well, there were some resistance markers for the cytochrome P450, markers that show metabolic resistance, and which PBO really targets. So these occurred at intermediate to high frequencies. So moving on now to after the baseline, this is the way clusters were randomized. So as I'd said before, 52 were randomized to receive non-PBO and 52 to receive PBO. But again, we did a proportionate kind of randomization, which was based on the number of nets available. So in the end, we had 37 randomized to permanent 2.0, 15 to OLISET, 32 to permanent 3.0 and Olisate plus 20. But then in the as treated kind of analysis, because there was, as nets were distributed, we got feedback on how the nets were distributed because we're not in charge of this. The Ministry of Health was in charge. So some of the clusters got different nets than were intended. So in the end, we had 39 which received permanent 2.0, 13 which received Olisate nets, and then 31 received permanent 3.0, and 18 received Olisate plus nets. So moving on to talk about trends, indicator trends for LLINs in the study area over the period of follow-up during these different surveys at 6, 12, 18, and as well 25 months. We saw that overall trends in LLIN ownership, adequate coverage, and use were similar in both study arms, as you will see in the graphs that are shown here. The blue line is the PBO arm of the study, and the red is the non-PBO arm, and you can see clearly that they were similar. The trends in ownership, adequate coverage being 1 net for every 2 people, and use, reported use on the night before the survey. So they are really similar across arms. And then LLIN ownership was high, really at all time points, and was almost as high as 80% even by the time of the 25-month surveys. Whereas adequate LLIN coverage fell to as low as almost 35% at the 25-month time point, as you will see in that graph. And reported use also fell to about 60% at the 25-month time point. So really the highlight here is that LLIN attrition is really an important issue within this area that we study over that period of time. Now, going to the main outcome of our study, this is the primary outcome, which is parasite prevalence, and looking at the non-PBO versus PBO arm of the study at 6 months, 12 months, 18 months, and as well at 25 months. Maybe I will just point out here that the 25-month survey, before we talk about the results, the 25-month survey results that I here are really from 90 of 104 clusters surveys, because these were supposed to be carried out in March, April 2020, but they were interrupted by COVID-19, and so we're really not able to complete those. But so the results presented here are really for the 90 clusters that we're able to do for 25 months. But then the rest for 6, 12, and 18 months, this is across the study area. So clearly we can see that there was, a reduction in parasite, prevalence, more like, parasite, the prevalence ratio was reduced significantly by, about 26% at 6 months. And, that is kind of, almost the same at 12 months. So about 27% difference there with, the PBO arms having a lower parasite prevalence than the non-PBO arms. And then still all the way actually 18 months and at 24 months, we are still seeing, a reduction of about 20% in the PBO arm compared, to the non-PBO arm in terms of parasite prevalence. And all these results were statistically significant, as you can all see. So clearly, we'll talk about maybe the summary of these results at the end, but then there's a clear significant difference between the PBO and non-PBO arms. So this is kind of showing the same thing, parasite prevalence, but looking at the trend, from baseline through 6 months, 12 months, and then 18 months, and 25 months. So we see in both study arms, parasite prevalence decreased from baseline, and it remained lower, than the baseline levels, through to 18 months. And then it seemed to begin to rise again at the 25-month survey. And really the changes, what we are pointing out here is that the changes from baseline were greater for both arms than the differences between the study arms, as you can see. Okay, moving on to the entomology evaluation. So we say 10 households from each of those enrolled in the community surveys in each of the 104 clusters. 10 households were enrolled for entomology evaluation, and we collected resting mosquitoes like you see in that picture using Procopac mechanical aspirators. and would aspirate for 10 minutes very early in the morning and would capture, all the mosquitoes there and identify the female anopheles and would adjust for baseline cluster level measures and within cluster correlations for, the entomology measures here. So now looking at the anopheles densities, the density ratio between the PBO and non-PBO arms, again, you will see that, there was a reduction, a significant reduction in mosquito densities, female anopheles mosquito densities between the PBO and non-PBO arms, a reduction of, close to like, 86% in the PBO arm versus the non-PBO. And as well at the 12-month, we see that that is, sustained and all through 18 months again and 25 months. And these results were again statistically significant with significant reduction in anopheles densities in the PBO arm versus the non-PBO. So this is my second last slide, the summary of the findings. Parasitemia and anemia varied widely by region. I've not presented the anemia results, but some clusters with parasite prevalence of 0 at baseline. So this is the baseline results. In the as-treated analysis, PBO LLINs were associated with lower parasite prevalence in children aged 2 to 10 compared to the conventional nets. And this happened all the way up to 25 months after distribution. And parasite prevalence reduced from baseline in both PBO and non-PBO study arms. The changes from baseline were really greater for both study arms than the differences between the study arms. But these findings are also supported by the secondary outcomes, especially the vector density outcomes that we've reported here. And then reported use of LLINs the night prior fell, to as low as 60% at the 25-month time point. So LLIN attrition is still an important issue. And 25 months net coverage is also associated. Lower net coverage is also associated with a rise in parasite prevalence, as we saw in that trend graph for parasite prevalence. So again, to acknowledge, all the different people, the Against Malaria Foundation, DFID, IVCC, Bill and Melinda Gates, who funded this work, and the Ministry of Health and all our different, teams and the local communities and all partners. Thank you.
Thank you so much, Sam. That was a fantastic talk. And we are going to move into the next breakout session where we'll be getting our hands on the lineup data and playing around with some of what Sam has showed us here. Thanks.
Just before we move to the